Okay, good evening, everybody. Welcome to the new edition of the Good Hormone Health webinar. Today's talk is entitled Growth Hormone Deficiency, PCOS, or Cushing's. How do you tell them apart? And please mute your phones during the talk, and we'll have time for using the chat button at the end for plenty of time for questions. This is a talk similar to what I gave at the Magic Convention, which some of you made, but I think many of you didn't, so I did want to talk about these topics today. The outline of today's talk is signs and symptoms of Cushing syndrome, testing for Cushing's, signs and symptoms of growth hormone deficiency, and testing for growth hormone deficiency, signs and symptoms of PCOS, and testing for PCOS, and then the most important part is how to tell them apart. In terms of Cushing syndrome, most patients don't have all the typical signs and symptoms. Many doctors have seen only one case of Cushing's, and textbooks may show only severe cases. The common symptoms I see with Cushing's are wired at night is the most common one, trouble sleeping, trouble falling asleep or frequent awakenings, severe fatigue, which is often new onset, abrupt weight gain without any causes such as decreased activity or depression, decreased ability to exercise, menstrual abnormalities, cognitive changes such as brain fog, low libido, symptoms of adrenal insufficiency, joint pains, can't get out of bed, nauseousness and vomiting, and depression, anxiety, and mood swings. Common signs I see include central obesity, muscle atrophy, thin skin on the top of the hand, which is called Little's sign, named after Grant Little, an endocrinologist at Vanderbilt in the late 50s, a buffalo hump, a round red face, bruising, extra hair growth, acne, loss of hair on your head, and stretch marks. So how do I diagnose Cushing syndrome? With a careful history and physical, changes in weight and body habitus, look at old pictures. And not all patients have all the signs and symptoms, especially early patients and what's called episodic or periodic patients, which I'll talk about. Most of the literature compares patients with severe Cushing's with normals. So most of the tests are designed to separate severe Cushing's with normals, but I prefer to diagnose people with early Cushing's and not severe Cushing's, so we have to change the paradigm of the testing. It's important to diagnose early because the sequelae, the consequence of Cushing's can be devastating. We don't want people to suffer for longer than they have to. The initial diagnosis of Cushing syndrome is the most difficult. Telling them different types apart is probably fairly easy. Treatment's not so difficult, but the initial diagnosis is hard. And I try to use as much information as I can. The gestalt, you can't just, people always ask me how many tests, and I sort of answer usually enough tests to figure out whether a person has it or not. We'll talk about a little bit, episodic or periodic Cushing's is common. So one positive test may be worth more than 10 negative tests. But, if you have 10 negative tests, that helps rule it out. A positive MRI helps, and a Ketoconazole trial, which I'll talk about also, is quite helpful. The Endocrine Society has been already 12 years since their consensus practice guidelines on diagnosis of Cushing's. First line tests are the urine-free cortisol, which I recommend, low dose or overnight dexamethasone test, which I don't recommend. You'll see why. And nighttime salivary cortisols, which I recommend. They've included testing for Cushing syndrome in patients with multiple and progressive sign features compatible with the syndrome, and patients with abnormal tests should see an endocrinologist undergo a second test, one of the above, or in some cases a serum midnight cortisol or a dexamethasone CRH test. What's the difference between episodic, cyclical, and periodic Cushing's? Periodic and cyclical refers to changes in cortisol levels that occur on a regular, predictable basis. Episodic refers to high cortisol levels that are somewhat random. Most of my patients are episodic. Some people are try to find like a period, but I think it's better just to determine that a person has episodic Cushing's and try to diagnose them with high cortisol when they're in their highs. Episodic Cushing syndrome is common. I think we wrote the definitive paper on this in 2010, titled in Hormone and Metabolic Research, entitled High Prevalence of Normal Tests Assessing Hypercortisolism in Subjects with Mild Episodic Cushing's. When we found that 65 of 66 patients with Cushing syndrome had at least one normal test of cortisol status, and most patients had several normal tests. These results demonstrated that episodic hypercortisolism is highly prevalent in patients with mild Cushing syndrome, and no single test was effective in conclusively diagnosing or excluding the condition. Rather, the paradigm for diagnosis should be a careful history and physical exam, and those patients in whom mild Cushing syndrome or disease is suspected, multiple tests assessing hypercortisol should be performed on subsequent occasions, especially when the patient is experiencing signs and symptoms of short-term hypercortisolism. So my approach is to do somewhere between 3 and 8 urine-free cortisols in the cortisol metabolites, 17-hydroxysteroids, 3 to 8 salivary cortisols in patients with a high degree of suspicion and symptoms of episodicity or periodicity. I don't recommend testing 100 consecutive salivary cortisols, as one of my colleagues does. If you have 5 of them positive over 100, it's a little hard to interpret that. I do recommend targeted testing. I recommend doing midnight serum cortisols at like an emergency room if they can be done. The patient should keep a diary of symptoms to correlate with cortisol values, and patients should try to collect the urines and salaries with high symptoms, as we talked about before. If the urines or salaries are normal, it makes active Cushing syndrome less likely at that time. Patients can evolve into it and should be examined in the future and should always be followed. So you need a test when you're on a high, the multiple urine-free cortisols and 17-hydroxysteroids, salivary cortisols at night. Midnight serum cortisol, the cutoff is 7.5. The test cutoff for most salivary cortisols is 0.09. The overnight or low-dose dexamethasone suppressants are not helpful in episodic Cushing's because you can be at a low very easily. I'll talk about my very low dexamethasone dex test. And pituitary MRI is good because you don't have to be in a high, and ketoconazole is also fairly good because you can lower cortisol at night and not give people adrenal insufficiency. So what are symptoms of being in a high? Wired at night, weight gain, acne, anxiety, increased mood swings and irritability, euphoria, more energy than usual, fewer joint pains and acne and aches, tasking easier, insomnia, inability to stay or fall asleep, energy levels that perk up after sunset, speed talking, the mind is going faster than your brain can process your thoughts to speak them, water weight gains such as edema, high blood pressure, high blood sugar, the patient has diabetes or hyperglycemia. A high period has sometimes for most people, but different people can have different signs. You have to distinguish the highs and the lows. The low phases are more nauseousness, weight loss, depression, lethargy, extreme fatigue, and muscle and joint pains. Patients should not test when they're in a low. They should test when they're in a high. I'll talk about this traditional overnight dexamethasone suppression test. You give a milligram of dexamethasone at either 11 p.m. or midnight and collect an 8 a.m. plasma cortisol. Cushing's patients classically have been thought to be resistant to glucocorticoid feedback. The old cutoff was 5. It went down to 1.8. And the cortisol assay isn't that good at low values. So it's very hard to tell whether 1.6 or 2.0 is that much different. And values greater than that are consistent with Cushing syndrome. Interesting enough, it hasn't been prospectively evaluated. It was decided on a paper, basically. It was a lab journal paper. It wasn't really tested. It was just proposed, but it's caught on. You can get high values on oral estrogens. A study showed that only half the patients with Cushing's, classic Cushing's, have a genetic defect leading to resistance to dexamethasone. It's probably lower in mild and episodic patients. And we did a paper in 2006 and updated overnight dexamethasone suppression test, limitations in mild and episodic hypercortisolism that showed that this test isn't that helpful in people with episodic Cushing's. We then revised this test to do a very low dose and the standard overnight and a low dose 2-day dexamethasone suppression test in episodic hypercortisolism. It was published in Hormone and Metabolic Research in 2017. We took 30 patients determined to have Cushing syndrome by biochemical testing and 14 patients determined not to have a condition. And they had the 0.25 milligram and the standard 1 milligram dexamethasone test and the 2-day low dose dex test. So it was a quarter of the dose of the standard dex. And we showed the results were pretty similar between patients that had Cushing syndrome and those not. However, a morning cortisol value greater than 7.6 following this very low dose of dexamethasone was found in 12 patients with Cushing syndrome and none in the excluded group, suggesting that a high cortisol value after this low dose of dex can indicate that further testing is warranted. The traditional 1 milligram dose or the 2 milligram 2-day dex suppression should no longer be used as a screening test in patients that could have milder episodic Cushing's while the 0.25 milligram, the quarter dose can be used to pick up some patients with Cushing syndrome. So our conclusion shows that the susceptibility to the 1 milligram overnight or 2 milligram 2-day should not be used to exclude patients with having suspected of having mild or episodic Cushing's. A high cortisol following the 0.25 milligram tests suggests the patients could have Cushing's and should be evaluated further, and they should be screened with other tests, including nighttime serum or salivary cortisol measurements or urine-free cortisol. What about the MRI? We did a paper in 2007, published in Hormone Metabolic Research, with the 3 Tesla MRI. Originally, the paper was done when I was at the NIH in 1994, suggests that 10% of normal volunteers have an MRI consistent with an adenoma. In the literature, only half the people with older, low-power MRIs had a tumor. We found I think the consensus is the MRIs are very good at picking up small tumors now, and that they can pick up a positive tumor in most patients with Cushing's. If they have a negative MRI, it somewhat excludes pituitary Cushing's. They could still have adrenal or ectopic Cushing's, but it's unlikely they have pituitary Cushing's, which is by far the most common cause of Cushing's in my patients. Most of the patients I see have pituitary Cushing's disease. The 3 Ts are high quality. Most pituitary tumors are seen on the MRI. It's very important to get a high quality MRI, which is why I developed an MRI checklist, which is on my website, to try to guide the imaging centers to do it properly, and to use a 3 Tesla machine and to do it dynamic, looking at the blood going into the pituitary and out of the pituitary. You can have an incidental loma, you can have a pituitary tumor and not have Cushing's, but it does give an important piece of information. And a negative MRI pretty much excludes pituitary Cushing's. If you have a low ACTH, you can have adrenal Cushing's. If you have a very high ACTH, you can have atopic. But most of my patients have this mildly elevated ACTH that would be consistent with pituitary Cushing's, but a normal MRI would make it less likely. I've been for about 5 years or so using ketoconazole as a trial. Ketoconazole is a medicine that was FDA approved for fungal infections, but it was found to block cortisol synthesis quite effectively. The main side effect is increased liver tests, which usually occurs at doses greater than 1,000 milligrams per day and is reversible. I have people usually take 400 milligrams a day, so we don't get into much trouble with the liver function test, but I do watch it carefully. Ketoconazole interacts with a lot of drugs, but a lot of these can be dealt with changing the other drug or watching the side effects. It has a short half-life, which is a plus. So I like to give it at night. I'm not sure why other endocrinologists don't do that. Cushing's is a disease of high cortisol at night, so I like to give the ketoconazole at night. And I usually have people take 200 milligrams at 8 and 10 p.m. and take 5 milligrams of hydrocortisone in the morning if needed, if they get adrenal insufficient. Most people have high cortisol at night and sort of normal during the day, so they don't get adrenal insufficient with this drug, but a lot of them, their symptoms get better, and it's nice to see that their symptoms get better on this. So I use a diagnostic to determine which symptoms a patient has are due to high cortisol. I use it in patients I'm pretty sure, but not completely sure, has Cushing's. I don't want them to feel better. I'm concerned if somebody doesn't get better, do they really have Cushing's? I've kept people on ketoconazole for up to 3 years without a problem. I often stop it for a round of testing, or if a patient develops a tumor on MRI, and then I would go back and just take them off and do more testing. And I also like to give vitamin E 400 units a day to help protect the liver so they don't get the bump in the liver function test. Okay, we're going to switch to the second topic of the evening. This is growth hormone deficiency. Growth hormone deficiency can often be part of hypopituitarism, and growth hormone is the first hormone to be affected if the pituitary is damaged. There's an order of hormone deficiencies. Growth hormone is first, gonadotropins, FSH, and LH are next. TSH is third, ACTH is fourth, prolactin is fifth, and posterior pituitary hormones are last and rarely affected. And we published a paper with my colleague Kevin Ewan in 2008, looking at patients with microadenomas. These are small tumors that were thought to be non-secreting tumors. They actually had a normal serum IGF-1 level, 19%, usually low normal. 19% of them, or half of them, were found to be growth hormone deficient. They had a higher BMI than those who passed. We did our GH RH test, and the people that failed the growth hormone test had weighed more and had a higher body mass index than those who passed it. 19% of them, or half of them, had at least one other pituitary deficiency, including and testosterone deficiency. So we concluded that a substantial number of patients with non-secreting pituitary microadenomas were growth hormone deficient despite normal IGF-1 levels, and had at least one other pituitary hormone deficit, suggesting that non-secreting microadenomas would not be clinically harmless and should be worked up for growth hormone deficiency. So patients with low IGF-1 and microadenomas have a good chance of being growth hormone deficient. Many endocrinologists only test for hypopituitarism if the patient had prior surgery or radiation. My approach is to measure the pituitary hormones first in patients with symptoms of hypopituitarism and growth hormone deficiency. And if it points to hypopituitarism, then get an MRI. And if the MRI shows a small pituitary or tumor and the IGF-1 is low, and the patient has symptoms of growth hormone deficiency, then to do a growth hormone stimulation test. Growth hormone deficiency is pretty common. There are more than 50,000 adults in the United States with growth hormone deficiency diagnosed total. Growth hormone deficiency is part of hypopituitarism. It suggested that patients with hypopituitarism that have increased mortality may be due to growth hormone deficiency. So we had a lot of studies showing patients with hypopituitarism die earlier and are sicker, and a lot of this is thought to be to growth hormone deficiency. Growth hormone deficiency in adults results in decreased bone formation, increased fat mass such as central obesity, decreased muscle mass, lipid abnormalities, increased thickness of blood vessels, increased inflammatory markers, impaired quality of life, increased number of sick days, impaired exercise tolerance. The good news is most of these symptoms are corrected or improved by treatment, and most of the treatment studied so far has been double-blind studies. So it does look like that the growth hormone deficiency is something that gives you poor quality of life, medical problems, and can be reversed by treatment. So if left undiagnosed, adult growth hormone deficiency may lead to increased risks for premature mortality, significant morbidity, or being sick. Multiple signs and symptoms. These include increase in body mass, decrease in muscle mass, weakness, fatigue, osteoporosis or thin bones, decreased rate of fractures, poor lipids, dyslipidemia, cardiovascular disease, and impaired psychological well-being such as anxiety, isolation, or depression. So how do you diagnose growth hormone deficiency? First of all, people make this mistake a lot that are not really experts in pituitary physiology. They measure random growth hormone. Growth hormone is pulsatile, so it's not really helpful. You can be at the top of the pulse or the bottom of the pulse. So what you do is you need to measure the IGF-1. So I screen with the IGF-1 if it's in the top of the 50% of the normal range for age and sex, somewhere around 150, depending on the assay. Growth hormone deficiency is less likely. If the patient has empty cell, a history of head trauma, headaches, and low blood pressure after delivery, or Sheehan syndrome, history of pituitary surgery or radiation, or pituitary tumor, growth hormone deficiency is more likely. If it's less than 75, well below the range, growth hormone deficiency is likely. But most of my patients are in this lower 25 percentile of the normal range, somewhere between 100 and 125 with their IGF-1. It's worth testing with a stimulation test. The stimulation test is required for diagnosis. In order to really truly treat a patient with growth hormone deficiency, they have to fail their stimulation test. Now, there's different stimulation tests. The most common one, and the one that we use the most, is called a glucagon stimulation test. And the cutoff is different for different societies. In general, Endocrine Society recommends 3. I often use 5 as the cutoff. You can also use a test called the insulin tolerance test. 5 is the cutoff. And you can do a new test I'll talk about in a second called the macro stimulation test. So for growth hormone stimulation test is essential. You can see over here the IGF-1s. They're mostly in patients with growth hormone deficiency. They're low, but some of them you can see here's the green lines are the normal range for age. Many patients with growth hormone deficiency are in the normal range. Most of them are below the normal range. They're all sort of near the bottom of the normal range. But the growth hormone, the IGF-1 is a screening test. It's integration of growth hormone. You need to do the stimulation test especially if they fall in this lower area. Now, there's different testings. The landscape is changing. The traditional one is called the insulin tolerance test. We don't do this test. The patients don't like it, and the doctors don't like it. It involves an intravenous injection of insulin, causes your blood sugars just to go low, and you would compensate by a response in growth hormone. The test is 6 blood draws, 2 hours minimum. It requires intensive medical supervision. It's not good in patients with epilepsy, older patients with heart disease, history of strokes, ischemic heart disease. You get low blood sugar almost by definition. Some people can pass out, lose consciousness. You can get lower blood sugars later. You can get seizures. It's really not a good test to do. The standard test that we've been doing for probably about 10 years is the glucagon stimulation test. It involves an intramuscular injection. There's 9 blood draws. It takes 4 hours. It doesn't need much supervision. It's a problem in malnourished patients who haven't eaten for 48 hours, patients with fasting hyperglycemia, Side effects include nausea, which is quite common, and therefore we give people Zofran before the test or have Zofran on board, vomiting, headaches, delayed low blood sugars, sweating, and abdominal cramps. The newer test is called the Macron test. It's an oral test, so it's a lot of advantages. It's only 4 blood draws. It takes 1.5 hours. It doesn't need much supervision at all. There's no contraindications for it, or that's recommended to be fasting. The main side effect is dysgeusia, which is like a bad sense of taste. Dizziness occurs, fatigue, headaches, nauseousness, and hunger can all occur. So these are the different tests that one can do. And we're offering both the glucagon and the macrolide in our clinics on Tuesday night. The pluses and the minuses are listed here. The glucagon test costs $695. It does not need a pre-authorization. It does require an intramuscular injection. Most patients get nauseous, and we use 7 blood draws for it. The macrolide stimulation test costs $350. It does require pre-authorization that many insurances don't cover. So if you don't cover it, you're stuck with paying $5,000, which nobody wants to do. And less insurances are covering it than I think the company liked. We can look in to see if your insurance covers it. Many do, some don't. It requires a pre-authorization that may take about a month. The pluses are it's an oral solution for blood draws. So how do you treat people with growth hormone deficiency? It's usually covered by insurance, especially if you fail your STIM test. We are pretty good at fighting for insurance to cover it. Insurance companies try to weasel their way out of highly expensive drugs like growth hormone, so often they try not to pay for it. Judy's very successful about appealing, and usually we get it covered, and we'll try our best. But if somebody has a very difficult insurance or didn't fail their, or had a borderline STIM test and they want a lower value, sometimes it's not covered. But there's some good news is there's cash pay for growth hormones. There's a new one called Zomactin, which is less expensive, works very well. It's $100 for a 5 milligram dose. If the dose is 0.4 milligrams, it will last 12 days and cost $250 a month, which is quite reasonable. We have 2 compounding pharmacies, University Compounding Pharmacy and Ocean Breeze Pharmacy, that does sell this. It's a really, it's becoming more possible to treat people that just don't have insurance and insurance doesn't cover it. There's different amino acid blends that seem to help the pituitary grow back. I'm really excited about a product by one of my patients from Northern California. Introduced me to this one called Otropin. It's from a company called Orenda. It's supposed to help restore the pituitary. It's amino acids delivered by liposomes. I haven't had too many patients on it yet, but the ones that are on it seem to do well on it. And I think in the next couple of months, I'll find out how their IGF-1s are turning out. It's only $48 a month. The one I've been using for years is called Cerevital. You can get it at cerevital.com or Costco, but it's like twice as expensive. It's about $94 for a 40-day supply. And I think the Otropin's going to end up working better, but we'll have to see. Now, so what about Cushing's and growth hormone deficiency? You can't have both. People ask me that question. The reason is cortisol suppresses the growth hormone releasing hormone, growth hormone IGF-1 axis. You can also have a pituitary tumor that causes Cushing's and causes a growth hormone deficiency. We think that the tumor, as we did in the paper with Kevin Ewan, the microadenoma paper, the tumors affect blood flow to the pituitary, especially to the cells that make growth hormone, and therefore you can get growth hormone deficiency from a tumor. Pituitary surgery for Cushing's can lead to growth hormone deficiency. Growth hormone deficiency increases the enzyme 11-beta-HSD1 and causes more conversion inside the cell. It's not in the blood, it's inside the cell, from inactive cortisone to active cortisol. So your cortisol inside the cell goes up. You can feel a little cushingoid from growth hormone deficiency, but it doesn't change blood levels. But it can people with growth hormone deficiency can easily look like people with Cushing's because of this effect on the 11-beta-HSD1 enzyme. And finally, I'm going to talk about PCOS. Dr. Chang says PCOS is an endocrine disorder that affects over 7 million women. That's more than the number of people diagnosed with breast cancer, rheumatoid arthritis, multiple sclerosis, and lupus combined. PCOS affects multiple parts of the body. You can see this nice little schematic I like here. In the head, it causes male pattern baldness and depression. In the face, it gives extra facial hair, coarse hair growth, masculine features. On the skin, it gives dark patches or acanthosis nigricans. It can give cystic acne. In the abdomen, it can give weight gain. In the pelvis, it can give thickening of the wall of the uterus. Polycystic ovaries, and multiple cysts can be seen on ultrasound of the ovaries. Although this is not required, the endocrinologists seem to pay less attention, including me, on the ultrasounds. You can still have PCOS with a negative ultrasound. You can have pelvic pain from these cysts. You can have very commonly, one of the main symptoms of PCOS is irregular menses, and you can have infertility. PCOS does stand for Polycystic Ovarian Syndrome. When I was in my fellowship, we learned that the PCOS can be ovarian, adrenal, pituitary, or hypothalamic, and I think I still agree with that. There's multiple causes of it, and there's multiple subtypes. It could be a GnRH issue in the hypothalamus, issues with LH and FSH in the pituitary. It can be due to high insulin or insulin resistance, which gives you weight gains, the skin changes, and the fungal infections. It can be an ovarian problem. You can be an adrenal problem where you make too much DHEAS. And it could be a testosterone problem or increased conversion from estrogen to testosterone, giving you acne, facial hair, male pattern, baldness, and masculine features. Endocrinologists place most of the emphasis on high androgens, testosterone, and DHEAS, and insulin resistance. Gynecologists place more emphasis on the pelvic ultrasound, showing a string of pearls. Some don't even measure the testosterone, which I don't think is correct. And PCOS has several etiologies: ovarian, adrenal, pituitary, and hypothalamic, and has gradients mild to severe. PCOS is part of the metabolic syndrome, which includes insulin resistance, abnormal lipid measurements, obesity, and high blood pressure. And it may be harder to lose weight if you have PCOS. But the main treatment for PCOS is weight loss and a healthy diet, including what I would say would be a low-carb diet. I think it's really crucial for PCOS. There's a lot of health consequences of PCOS. It includes the hyperinsulinemia and insulin resistance. You can eventually go into type 2 diabetes because it affects your beta cell function, and you have decreased insulin. The beta cells can't keep up with the insulin resistance and start failing. You can have obesity. You can have high lipids. It increases your cardiovascular risk factors, including getting a heart attack, and you can have a higher rate of endometrial cancer. The reproductive consequences of PCOS are quite profound: increased prevalence of menstrual disorders and hyperandrogenism or high testosterone levels, reduced response to ovulation induction, requires higher doses, so it's harder to get pregnant with IVF, increased prevalence of miscarriages, higher prevalence of pregnancy complications, including gestational diabetes. So I like to try to exclude other etiologies of extra androgens and irregular periods. These include include Cushing syndrome, we talked about before, prolactinomas, perimenopause or menopausal issues, and what's called congenital adrenal hyperplasia, where you have high levels of a hormone called 17-hydroxyprogesterone, and this could look quite like PCOS. So we do measure the 17-hydroxyprogesterone to exclude this condition. Symptoms of PCOS include irregular no periods, facial hair, acne, infertility, can't lose weight, and hair loss. Laboratory test I like to do would be the most important one is the bioavailable testosterone with the total testosterone and the sex hormone binding globulin, or SHBG. DHEAS is also quite high in PCOS, and I always measure that one. I like to get a day 3 LH, FSH, and estradiol to exclude perimenopause or menopause. We do the Cushing's test we talked about before, 24-hour urinary free cortisol, 11 p.m. salivary cortisols. I like to get a prolactin because high prolactin and prolactinoma can give you irregular periods, 17-hydroxyprogesterone to look for congenital adrenal hyperplasia, hemoglobin A1C to look for prediabetes and diabetes, and I often like getting a fasting insulin and glucose level to look for insulin resistance. This hormone, sex hormone binding globulin, I think is underappreciated. It's very important. It's a protein that binds both testosterone and estradiol. It can vary widely in patients. So you can think that your testosterone is normal, but your SHBG can be high or low, and therefore cause your testosterone to vary widely. That's why I measure the bioavailable testosterone, which shows the active form of testosterone. So I like to measure the SHBG and the bioavailable testosterone in all women that are being evaluated for PCOS. The free assay is not that good, so I usually don't get that unless it comes along with it. But the bioavailable testosterone, as well as the SHBG in the total, is quite an accurate way to look at the androgen status of a woman. SHBG is reduced in insulin resistance and obesity, so most PCOS women have a low SHBG, which makes their bioavailable testosterone look higher. It's a good marker for insulin resistance, actually. Many women with PCOS have a high normal or even a normal testosterone level, but a low SHBG, and that shoots up their bioavailable testosterone. And this is, again, because they have insulin resistance. And I like using a cutoff of a bioavailable testosterone around 8 to diagnose PCOS. So greater than 8 is more consistent with PCOS. Less than 8 is not consistent with it. Birth control pills and other forms of oral estrogen, not transdermal estrogen, oral estrogen, raises your SHBG and give a higher total testosterone than if the SHBG was normal. These patients have a normal or low bioavailable estrogen and bioavailable testosterone. A study found that birth control pills can raise SHBG, and even stopping them for at least a year, the SHBG remains high. And because the SHBG is high, the bioavailable or active form of testosterone is low, and a female patient often has low libido when on estrogen, even when off of it even off the birth control pills for a period of time. SHBG is not affected by transdermal estrogens such as estrogel or an estradiol patch, and it seems like oral progesterones, progesterone or Provera may raise SHBG, but less than oral estrogens do. So I'm always trying to figure out, again, as the sort of the title of the talk is, whether the person has hypopituitarism with growth hormone deficiency, PCOS, or Cushing's. All these conditions can give you acne and extra facial hair and body hair. The testosterone is usually high in PCOS, and I did a study that was published about 10 years ago in European ECED, European Journal, that shows that the bioavailable testosterone is usually low in Cushing's or hypopituitarism. So my paper published about 10 years ago used a total testosterone of 31 done in esoterics. If it's greater than that, it's more consistent with PCOS. Less than that, more Cushing syndrome. Patients could have both PCOS and Cushing syndrome, and a very high testosterone, greater than 100, or DHES greater than 500, can indicate an ovarian or adrenal tumor, and it's worth getting an ovarian ultrasound or adrenal CT or MRI if that is indeed that high. An interesting paper came out from an Italian group in 2003 showing that PCOS may be a state of hypercortisolism. Patients with PCOS had higher urinary free cortisol than obese controlled, but lower than Cushing's patients. It's also thought, although it's less well studied, the 17-hydroxysteroids, the metabolites of cortisol are also high in PCOS as well. Midnight serum cortisols, at least in this paper, and probably nighttime salivary cortisols and post-dexamethasone cortisol are similar in PCOS as in obese patients, and much less than Cushing's. So what I usually do is I usually treat PCOS simultaneously with working the patient up for Cushing's. If the UFC goes down in a patient with suspected of having PCOS and Cushing's, that's a good sign. It maybe means they don't have Cushing's, but I do reevaluate them after treating them for PCOS. The medications in PCOS, I'm not going to talk about too much today. They're in my article on my website, called PCOS Diagnosis and Treatment, which I think was one of my better articles. It talks about the different doses you can use for the birth control pills are possible. Birth control pills have the advantage of many people with PCOS want to get pregnant, and birth control pills seem to do the opposite of that. So I use very little birth control pills. Spironolactone is a good medicine. Metformin, flutamide is a medicine used off-label, blocks the action of testosterone and decreases testosterone synthesis. It's a very good medicine to lower testosterone. And statins like Lipitor are very good also for lowering your testosterone levels. I like supplements. Again, they're in this article called PCOS Diagnosis and Treatment. The supplements probably work as well as the medicines. I like using the combination of resveratrol, myo-inositol, NAC, and omega-3. The first two, I think, are the most important ones, but the other two are helpful too. And I usually have my patients take all four of them. So my approach is to tackle all three. We do the Cushing's testing, we do the MRI, we get the bioavailable and total testosterone DHES to look for PCOS. I treat the PCOS with either supplements or the pills. We measure the IGF-1 and it's followed by a growth hormone stimulation test. If you fail the growth hormone stimulation test, I would treat you with growth hormone, and hopefully one of these things will cause the patients to improve, or it becomes clear whether they end up with Cushing's, PCOS, or growth hormone deficiency. So this is a table that I created that tries to show the different symptoms in the different diseases. It's not foolproof, but I think it gives a good idea. Weight gain is more common in Cushing's, middle common in growth hormone deficiency, and less common certainly occurs in PCOS. Irregular periods are more common in PCOS, less common in growth hormone deficiency, in the middle in Cushing's. Daytime fatigue is quite common in Cushing's and growth hormone deficiency and occurs but less commonly in PCOS. Acne and facial hair are most common in PCOS and Cushing's, less common in growth hormone deficiency. Hair loss is common in all of them. Poor sleep can occur in all of them, but it's more common in Cushing's. Joint pains is more common in growth hormone deficiency, but can certainly occur in Cushing's and a little bit in PCOS. Depression and mood changes are more likely in Cushing's, but can occur in PCOS and growth hormone deficiencies. And infertility is more common in PCOS, can occur in infertility, and then can occur less likely in growth hormone deficiency. So this is a guide on your symptoms, but you definitely need the testing to see which of these buckets you fall into. Okay, so we did this in 35 minutes. So the talk will be posted at goodhormonehealth.com in a couple of days. If you have any questions, feel free to email me at mail@goodhormonehealth.com. And we will open this up to the chat. Let me look at the chat. Please feel free to ask me questions on the chat. We'll start with Caitlin's question. Is it possible to develop pituitary adrenal ectopic Cushing from exogenous cortisol? I feel after long-term discontinued exogenous exposure, the symptoms are still very much in me to see if there's an internal source. I have PCOS and they think they cannot occur both simultaneously. So definitely PCOS and Cushing's can occur simultaneously. The steroids, exogenous steroids, should give you low cortisol once you stop them. So my guess is that Caitlin had maybe had low cortisol, but now it was probably looking for high cortisol. So he or she should be tested for, probably it's she, since it's PCOS, she should be tested for Cushing's now that she's off the exogenous steroids, and she should be tested for PCOS and be treated for both. Amanda asked, what does high AM blood cortisols indicate? So I did a paper actually when I was at the NIH with my good colleague Jack Yanofsky in the early 90s, looking at high blood cortisol. It was not helpful for Cushing's. So Cushing's is a disease of high cortisol at night. The morning cortisols are usually fairly overlap with normal people or pseudo-Cushing's people. So high AM cortisol doesn't mean that much. Similarly, patients on birth control pills or oral estrogen raises their cortisol binding globulin, and it can make people have what looks like high AM blood cortisols without having Cushing. So I don't really put too much weight into high morning blood sugar, blood cortisol. If it's quite high, your ACTH is quite high, it can mean a little bit, but the testing for Cushing's needs to be at nighttime or 24-hour urine. Tori asks, for the growth hormone stimulation test, is it both tests or one depending on which insurance covers? In general, it's one test depending on which insurance covers. There are a few insurance companies that say they want two tests. I try to argue with them. I usually win, saying that's not what the Endocrine Society wants. We usually win, but occasionally insurance companies will want to be difficult, so they'll make people do two tests. But usually one, and usually they cover for the drug, the glucagon's less expensive, but hopefully they'll cover the macron also. Tamara asks, can you have all three? Yes is the answer. You can have all three, and hopefully you should be worked down up for all three of them. Charlotte asks, can somebody have PCOS and growth hormone deficiency? Yes, you can have that too. So it's a little less likely because the cause of growth hormone deficiency is usually hypopituitarism, which would give you low testosterone. So it's less likely, but people can. I've seen people with hypopituitarism and PCOS. Your ovaries are quite active, and then you have hypopituitarism still, and you have both of them. Caitlin says thank you. Tiffany says, is it possible to have adrenal and pituitary adenomas and not have Cushing's? Yes. So people can have tumors on imaging called insulomas, and adrenal tumors are quite common, mostly benign, don't do anything. Pituitary tumors also can be benign and not do anything. So the test for Cushing's is the imaging plus the biochemical testing of the high salivary cortisols, the high urinary cortisols, or the high midnight serum cortisols, and signs and symptoms of it as well. If you do have this issue with adrenal and pituitary adenomas, and you do end up with Cushing's, you should see what your ACTH level is. A low ACTH, usually less than 10, is consistent with adrenal Cushing's, and an ACTH sort of around 20 to 40 or so is consistent with pituitary, and a higher ACTH is consistent with ectopic. Tori says, any thoughts on why someone would have symptoms at night, unable to sleep? But still have a low salivary test. If possible, the person is not testing when they're really in a high. It could be. So just try to test, different times when you're in a high. It does sound like, I suspect Tori does have Cushing's, so we just have to get her to test when she's in a high more. Some of her tests are positive. Mrs. Washington says, will Cerevital or Otrova provide improvements in someone without growth hormone deficiency? So I think people can have sort of mild growth hormone deficiency. Somebody can have a low IGF-1, and you can take the Cerevital, the Otropin, and get it up. The patient could have some damage to the pituitary and not be full-fledged growth hormone deficiency and could benefit from it. But I'd recommend some kind, at least testing your IGF-1. Pat. Okay, Pat says, I have a low growth hormone. Where'd you go, Pat? I have a low growth hormone, but told I should not treat because of an ongoing CSF leak. I don't agree with that. I think this CSF leak should be fixed, first of all, but I don't think growth hormone makes CSF leaks worse. So I think it's okay to take it. M. Posen says, can a keto diet exacerbate Cushing syndrome? I would say probably not. I think a high carb is more likely to, but there's I think different people can vary differently, but probably should not affect it. Is there a supplement that can raise T? I'm not that sure about that. There's certainly for men there's some, but for women, I'm not so sure if there are one or not. Rebecca asked, is the diagnosis of AVN highly correlated with Cushing's? It could be. I wouldn't say highly, but people with AVN should be tested for Cushing's unless they had exogenous steroid exposure, which also gives avascular necrosis. Charlotte says, do growth hormones range on labs from day to day like Cushing's can? Well, growth hormone is pulsatile. So I would say growth hormone can certainly, but the IGF-1 shouldn't vary that much. It might vary a little bit, but not that much, because the IGF-1 is more integrative. Linda asks, if you had a cortisol stimulation test, would this show if you produce excessive cortisol as opposed to low cortisol? No. So the Ketoconazole test is only helpful for low cortisol. It doesn't help you for high cortisol. I'll make this chat a little bit bigger so we can see more patients. Questions? Adina. Hi, Adina. Long time no see. It's nice to hear from you. Thank you for your webinar. Do you recommend Cerevital or Otropin in patients with pan-hyperthyroidism Sheehan? Yes, I would recommend them both, and I would recommend probably Otropin over Cerevital right now. Elaine asks, what other places beside the tumor on the pituitary and adrenal gland can cause Cushing's disease? You can have ectopic Cushing's too. It's less common. It's usually more severe. You can have it in your lung or in your thymus, for example. Patients with that would have a higher ACTH. Caitlin asks, I have a large growing lump on my neck near my buffalo hump. Is it possible that it's a lipoma? I know it's possible it's lipoma. However, is there a chance it could be an ectopic source? It sounds like a lipoma to me. It is hard and fixed due to the size it does have a bit of movement. If that makes sense, my PCP won't answer the questions. Ultrasound said it's a suspected, I guess, lipoma. It probably is lipoma. It's probably not related to your Cushing's. Katori says, thank you, very informative. Amanda says, do antidepressants affect testing? If so, how? So most antidepressants lower your cortisol to a degree. Your SSRIs lower your cortisol to a degree. It's partly how they work a little bit. It's not that much, and I usually depends on how bad the patient's depression is. So some people, I try to get them to stop their antidepressants for a couple of days before they're testing, but it's probably not that big of an issue. Sharon, if diagnosed with Cushing's, where's the best place for treatment? In Southern California, surgery the only option. So I think Sharon's due for a phone call with me. Medicine is definitely a possibility. I like the Ketoconazole. It works quite well in a lot of people. So that would definitely be an option. And there's different surgeons I work with in Southern California. We can talk about that at your next appointment. Somebody needs to mute their phone. David, can you mute your phone? Thank you. Anybody else? Lori, can you mute your phone? What else we got here? Minerva. Okay, that looks like most people. Sybil, mute your phone also. Okay. Linda S asks, when replacing low growth hormone medication, why is the medicine cause excessive water retention, swelling. That's part of what growth hormone does. And that's one of the main side effects is the swelling. So you have to balance your, what the IGF-1 is. If the swelling is high, if the IGF-1 is high, frequently I see the swelling and water retention. You have to watch the IGF-1 and see lower the dose if you're getting this. Tamara asks, what is a low sex hormone binding globulin mean? It usually means insulin resistance. Sorry about that. It usually means low insulin resistance. Can be often thyroid disease, for example, but it usually means low insulin resistance. Similarly, a high SHBG is usually good. It usually means less insulin resistance. Can diabetes insipidus improve spontaneously? The answer is definitely yes. I see a lot of people as they go farther away from surgery, the diabetes insipidus gets better. Also, usually when people start on growth hormone, their diabetes insipidus gets better as well. Is cardiovascular instability, such as tachycardia, common with Cushing's and insulin resistance? Yes, I see that a lot in Cushing's. Is it common for Cushing's to feel worse at the same time every day, and then it gets better a certain time every day? Or a lot of people, patients insulin resistant? Yeah, so people can be going through lows and highs throughout the day. Usually people go low at the same time throughout the day, and then high at other times throughout the day. Usually people are high at night and sort of low often in the morning, and you can feel like lousy when you're low. And a lot of patients with Cushing's patients have insulin resistance. Okay. Tamara says, thank you for hosting the webinar. Elaine says, can you lose weight if you have Cushing's disease? It's hard. So I have patients that are pretty low symptoms of Cushing's because they really watch their diet and exercise. And then you can lose weight, but it's pretty hard. I would say it's less common. Is there a diet you recommend beside low carb? Mostly like a low carb, high vegetable, high protein diet, high lean protein diet. But eat a lot of vegetables are good. Rebecca says, my doctors don't seem to know what they're doing. I'm sick of being sick. How can I get them to ramp up their testing? How can I get an appointment with me sooner? I'm happy to see you go on the wait list. And I'm pretty busy now, but I'm happy to see all the patients on the webinar and try to get them to feel better. And I can't really vouch for other doctors. Many of them seem to be good, but they seem to be sometimes not able to wrap things up and make a diagnosis and get somebody to surgery or better. Even diabetes that happened due to Sheehan's without surgery, I think Sheehan diabetes insipidus, I've seen it get better with time. Kelly, nice to hear from you, Kelly. Thank you so much. You're always great. Mary says, if my IgG1 continues to follow reference range, yet my glucagon test is normal. Is this a concern? No, it's probably good. Can the IGF-1 be too low? But the IGF-1 is sort of a screening test. The growth hormone testing is the crucial one. But I recommended Mary to take the supplement, the Otropin. I think that will help her get her IGF-1 up some. And again, the IGF-1 is sort of a screening test. Some people with low IGF-1 fail their growth hormone test. Some people pass it. And the growth hormone stimulation, the glucagon test is the gold standard. What are the rates of cure with surgery? I presume for Cushing's, do many people require steroids? So the rates of cure, I would say about are 70%. I'd say my patients are usually sometimes a little bit harder. I do some of my patients are very good surgeons. That ups it a little bit, but my patients have a smaller tumor that may be less fully developed because I try to get people to go to surgery earlier. This may be harder to cure. Most people require surgery, steroids after surgery. I give everybody steroids because I don't want people to crash, and almost everybody needs it, but then I taper them off soon. Do you have patients that require the fluconazole after surgery? I'm not sure if she means fludrocortisone after surgery. Not too commonly. Fluconazole is used for fungal infections and is not the same as ketoconazole. It has less of effect on your cortisol. Can the IGF-1 be normal with failed glucagon? Yes. So the IGF-1 is a screening test. If the IGF-1 is in the upper normal, it's unlikely you'll fail. If it's lower, but still in the normal range, it is a good chance that you'll fail. There's a chance you'll fail the glucagon. You need to do the glucagon test. Amanda asked, can you see pituitary tumors on a 3-Tesla machine without contrast? Not that likely. So you need the contrast. It really shows the dye going into the tumor and out of the tumor. It's hard. If you have a big tumor, you could probably see it, but for the subtle ones, contrast is pretty needed. I haven't had any problem with the contrast. There's some people that have problems with the gadolinium. Usually those are people with more kidney problems and older patients. I haven't had that a problem on any of my patients, so as far as I know. I did discuss with Janet this issue several years ago, but I think the Gattle is pretty safe. How soon do we get the results from the growth hormone test? Well, how soon will we feel better? The growth hormone test usually takes about a week to come back. The labs are just slower now because of COVID, and they're swamped with testing, so it's coming back a little slower. But somewhere about a week. And how soon will we feel better? I like to get the IGF-1 up to the second half, middle half of the range, upper half of the range. Usually doesn't take that. You usually don't feel that much better until you get that. So we usually titrate up. So in a couple months or so, some people feel better right away. Linda S. asks, thanks for your webinars. Always appreciate the information. We'll be hosting a webinar oxytocin deficiency. I gave one before. It's on my website, but we can repeat it. Is it possible to have essential obesity with Cushing's? Can it cause your abdomen to fluctuate in size? I would say yes. Your cortisol can fluctuate and your abdomen can fluctuate. Mine is always firm and hard, but gets bigger after eating, causes so much discomfort. Is it possible to have hypothyroidism with normal labs, meaning my personal hormone threshold should be at a high range of normal, not being there to causing my symptoms? I have a micronadenoma and many symptoms. The lab tests are crucial for Cushing's. You really can't diagnose people without having highs. My guess is you're maybe not testing when you're not high, but it does require signs and symptoms, tumor, and lab tests to really proceed with surgery. Janet asked regarding growth hormone replacement. Now the mini quicks are on back order. What do you recommend to replace them? It's a big problem, and I don't know why they're so on back order. Some people we have to do combinations of. Some of the doses are available. Some people we have to give it 6 days a week if they're on a lower dose than what they have. We usually work out one answer or another. But I think most of the growth hormones are somewhat similar. People like the mini quicks, but if they're not available, I don't think the pens are that much worse to them. They're a little bit more inconvenient. But rather than going off growth hormone, I would recommend some type of growth hormone, usually a pen. If your ACTH and cortisol are both low, you don't have Cushing's, right, unless you're cycling through a low. So I said most people are episodic. You can have lows and highs mixed in together. So this person, if they have a lot of signs and symptoms, should be tested again when they're maybe in more of a high. Adina says, can diabetes insipidus improvement be the cause of extremely low sodium and electrolytes? Yes. So if you're treated with DDAVP and you don't need it, then you can get low sodium, and you should taper down, gradually, or depending on how much you're on. You can maybe stop it and see how you do. How many 24-hour urines can you have before you definitely rule out Cushing's? It depends on what else is going on, the labs, the imaging, the symptoms. I think if somebody has a lot of symptoms, has a pituitary tumor, you have some high salivary cortisols, I would do a lot of urinary tests. Some people, I don't feel that strongly they have Cushing's. They have something else that comes up, the growth hormone deficiency or PCOS, and we try to treat them, and they feel better. Then you can sort of stop testing your Cushing's. Amanda says, with Cushing's, can you have stretch marks that have faded from the dark purple ones that they first appeared years ago? Yes, you could. I think the stretch marks can come and go and can go down, but the darker stretch marks that are present now are more likely to be a sign and symptom of active Cushing's. Okay, it looks like I'm answering most questions. Any more questions? Mary says, are recurring random or oral lesions sore mouth feature of Cushing's? I would say probably not. Mouth sores, probably not. Adina says, do I need a way to confirm my pituitary gland awakening before trying to lower or stop my medicines? I believe it's possible for me to cover, and I think that'd be awesome. I haven't, I'm happy to talk to you. We have an appointment, coming up and sort of taper you down. I would be cautious about stopping everything, but you can sort of taper down. If you have another doctor following you, I would do that, do testing, and we can follow you, do some testing, see how you're doing. But it's good that I think people can recover from Sheehan's, and I'm glad that Adina seems to be recovering. I think she'll be able to get off a good portion of her medicines. Would a buffalo hump occur with PCOS too? PCOS can be a sign of hypercortisolism, as I showed that Italian paper. I think it's buffalo hump makes Cushing's more likely than PCOS, but you need to do the testing for both of them and treat the PCOS if that's the case. Kelly says, according to Pfizer, they had a manufacturing issue last year and are currently focused on filling back orders. They'll be getting the higher doses first. At the time, they expect to resolve it all by November. Thank you, Kelly. That would be great if they got it all the growth hormone fixed. Presumably you're talking about growth hormone. Maybe you're also talking about cortisol, but there's also somewhat of a back order on cortisol. But hopefully that's getting better also. Is apoptosis associated with Cushing's? No, apoptosis is usually associated with Graves' disease, but there are other causes of apoptosis, but usually it's not Cushing's. Amanda, if you don't have a buffalo hump but have a neck fat, supraclavicular fat, it can still be indicative of Cushing's. Yes, so the supraclavicular filling, extra fat around your above your clavicle is a sign of Cushing's. Thank you for all that you've done to help us. Thank you, Janet, of course. Thanks, Janet, for all her help also. What UFC range do you consider normal? So it's normal for the lab. So, the esoterics for women goes up to 34. The Quest one usually goes up to 50. LabCorp goes up to 45 or so. So, and some LabCorp one is higher in males. So you need to look up for, you need to look at the normal range. Kelly says growth hormone mini quicks we were asked about. So hopefully they're coming back. Thank you, Kelly. Heidi asked, they believe my MRI shows possible tumor. My test came back normal. I was tested when I was on birth control pills. Should I never stop on birth control pills? Birth control pills affect your blood cortisol. They don't really affect your salivary and your urine much, but it's worth retesting again if you have a lot of signs and symptoms. Some people do better anyways off birth control pills. Birth control pills lower your IGF-1, so your IGF-1 may often go up off of it. So I think it's worth testing and see how you do off the birth control pills. Okay, 133 asks, I have a 9mm microadenoma and multiple endocrine neoplasia with various tumors, IGF-1 low, ACTH and cortisol low T, low DHEA, low progesterone. Adenoma, does the adenoma need to get bigger to cause hypopituitarism? No, I mean, 9mm is pretty big. I definitely think you could have hypopituitarism. We had the low growth hormone in people with small microadenomas. So I think a lot of your symptoms will be due to this tumor. Don't necessarily think you should have the tumor removed, but you should have your hormones replaced. Is extreme afternoon fatigue common with Cushing's? Yeah, so some people with fatigue is very common with Cushing's any time of the day. Partially is because of probably the cortisol, the poor sleep. So I would say daytime fatigue is very common with Cushing's, and afternoons is as good a time as any. Do you go by the lab's normal range when testing for Cushing's? Yes, I do. Adina, if you'd help me taper down, I'm happy to help you, of course. Okay, so I think we can stop here. It was a great discussion. We're at 7 o'clock. I'll post the webinar in a couple of days, and look forward to talking to everybody. Thank you from everybody. So nice to see you. I think it's a great topic, and we'll schedule something up in the next couple months. I think I might do something back on thyroid again, but we'll see. Send me your request if you have any, and you want to do oxytocin, we can do that also. Okay.